With respect to malignant mitral valve prolapse, or mitral valve prolapse believed to be the isolated cause of sudden cardiac death, an Italian registry of 650 consecutive cases of young individuals less than the age of 40 attributed mitral valve prolapse as the cause of 8% of cases, placing it neck and neck with hypertrophic cardiomyopathy and ARVC. A U.S. cohort of similarly aged individuals reviewed over a similar time period attributed mitral valve prolapse as the cause of sudden death in 4% of cases. A more recent cohort of 1,200 sudden cardiac death survivors at the Mayo Clinic revealed mitral valve prolapse as the trigger for arrest in about 1% of their population, 90% of whom were women. But to recap, about 20% of all 3 million yearly deaths in the United States are attributed to heart disease, with about 50% of those being due to sudden cardiac death, of whom about 4% in the U.S. are believed to be due to mitral valve prolapse, which, according to some literature, is similar to the number of sudden deaths attributed to hypertrophic cardiomyopathy. This 2020 JAMA article highlights that while the risk of sudden death due to hypertrophic cardiomyopathy is more than twice that of mitral valve prolapse, due to the higher prevalence of mitral valve prolapse compared to hypertrophic cardiomyopathy, the total number of deaths attributed to mitral valve prolapse is actually greater. So, is there a way to spot the proverbial Waldo who will account for 1 in 250 deaths this year, within the sea of 1 in 750 patients with mitral valve prolapse presenting to your clinic? The answer is, it's challenging, but next we'll take a look at techniques for risk stratification. In recent years, several signals have emerged which appear to increase the risk that an individual with mitral valve prolapse will develop malignant ventricular arrhythmias. Among them are many imaging findings, including bileaflet prolapse, which has been found to be over twice as prevalent compared to single leaflet prolapse among patients who developed sudden cardiac death attributed to mitral valve prolapse. This finding seems to be consistent across the globe, as this study of an Italian cohort of patients who suffered sudden cardiac death also found bileaflet prolapse in 70% of individuals whose death was attributed to mitral valve prolapse, which is similar to the 78% of bileaflet prolapse found in a Canadian cohort of malignant mitral arrhythmias. With respect to mitral regurgitation severity, while greater severity is associated with greater mortality over a 10-year period, the majority of patients determined to have mitral valve prolapse-related sudden cardiac death actually seem to have less than severe mitral regurgitation, with 65% having only trivial or mild regurgitation. Several studies have implicated mitral annular disjunction as a risk enhancer. Dr. Serrano's group at the Mayo Clinic examined a cohort of 600 patients with mitral valve prolapse over a 10-year period and found that of those that went on to develop ventricular arrhythmias, 44% had mitral annular disjunction. Similarly, about 50% of those with mitral annular disjunction went on to develop an arrhythmic event defined as VT or VF within 10 years, compared to 30% of those without mitral annular disjunction. It's important to note, however, that despite the increased risk for arrhythmic events, overall 10-year survival for this cohort of patients with mitral valve prolapse and concomitant mitral annular disjunction was very good, at 97%, and even higher than that of their non-MAD counterparts. As mentioned earlier, the increased traction forces produced by mitral valve prolapse and MAD are believed to induce myocardial fibrosis and scar. In this study of roughly 500 patients with mitral valve prolapse, the presence of late gadolinium enhancement in the left ventricular wall was associated with a 5-fold increased risk of ventricular tachycardia greater than 30 seconds or aborted sudden cardiac death with ventricular fibrillation, compared to those who had no left ventricular LGE. As mentioned earlier, you don't necessarily need a cardiac MRI to find evidence of high lateral traction forces caused by mitral valve prolapse and disjunction. The Pickelhaub sign, characterized by a high-velocity systolic lateral tissue Doppler signal, was found to be 3 times more common in patients with mitral valve prolapse who went on to develop malignant arrhythmias. Similarly, the double peak pattern, which may be seen on strain imaging in patients with mitral valve prolapse, is thought to reflect the effects of elevated traction forces during late systole and has been associated with increased risk for malignant arrhythmias. As a reminder, longitudinal strain looks at the distance between speckles in the myocardium to determine the extent of ventricular contraction in the longitudinal plane. Under normal circumstances, the strain becomes more negative during systole and less negative during diastole. During early systole, the strain pattern in mitral valve prolapse may look normal. But by mid to late systole, as the ventricular myocardium experiences opposing forces from the elevated traction on the cords, the strain signal becomes less negative. Then, during early diastole, when the tension is released, the strain signal briefly becomes more negative again, creating a double peak pattern, as demonstrated here in this paper by Dr. Nagata. This pattern, when present in patients with mitral valve prolapse, has been associated with a greater than 3-fold increased risk for developing ventricular arrhythmias. But echo and MRI aren't the only tools that can be used to risk stratify patients for malignant arrhythmias. ECG and Holter data also seem to share some signals as well. In this small cohort of 43 patients whose sudden death was attributed to mitral valve prolapse, 83% were noted to have inferior T-wave inversions on a recent 12-lead ECG, which has been hypothesized to occur due to repolarization abnormalities from increased stretch on the myocardium. When it comes to Holter monitoring, findings of complex ventricular ectopy have also been associated with high mortality rates. In a cohort of 600 individuals with mitral valve prolapse, those with faster VT, specifically greater than 180 beats per minute, had a 25% mortality rate at 8 years, compared to 10% for those with trivial or no ventricular ectopy. Fortunately, those with severe ventricular arrhythmias accounted for the minority of the cohort, with greater than 50% having only trivial ectopy. While the authors of this study included examples of what mild, moderate, and severe ventricular arrhythmias might look like, it's important to recognize that complex ectopy is not always about speed. Less frequent but short-coupled PVCs have also been implicated as risk enhancers in patients with mitral valve prolapse. And here we see that when the PVC falls just a bit too early, it initiates a run of polymorphic VT. And when PVCs occur in patients with mitral valve prolapse, they most commonly arise from the posterior papillary muscle, followed by the right ventricular outflow tract. And finally, there may be some risk signals in the clinical history and baseline demographics. In a cohort of 42 patients who received ICDs as secondary prevention after sudden cardiac death attributed to mitral valve prolapse, 95% were found to have symptoms of presyncope preceding the arrest, and 60% had syncopal episodes. And while several small studies with fewer than 50 patients have suggested that malignant arrhythmias occur with a greater frequency in women compared to men, larger studies with cohorts in the hundreds to thousands have found that the sudden death due to mitral valve prolapse is more evenly split between the sexes.